Morning.
Good morning.
How's everyone doing?
Good. Miss King,
Yes.
will you be, okay, how do I put it? Will you be recording this lecture?
I'm going to see if I can. What I recommend is that if you can record, like if a lot of people I know would bring their, like in class, people would bring their phones up and just record on your phone and just do the audio. So if you can do that, you certainly are welcome to do that.
Okay. I mean, good.
We'll give it just a few minutes. We're still just a little bit early. All right, I know a few more have joined. Looks like there's still a few more in the process, so we're going to give it just another minute before we get started. All right, it looks like we have a good bit on. I think there may still be a few that join in, but we can go ahead and get started. Well, good morning, everybody. Those that haven't met me yet, my name is Linnea King. I know I've had some of you in clinical last week, and then I had some of you in clinical in 111. So it is nice to meet everyone. I hope everyone is adjusting to our different methods right now and doing this. I wouldn't really say online, but just virtually because we're still doing it live. But it is definitely a little bit different. So throughout, the thing I want to stress the most, I feel like during this time, a lot of people probably have questions and are not reaching out as easy as if we were on campus and in person. So if you have questions, you guys should have my email address. I'm going to send you my phone number right now in the chat. So call me, text me, set up a time where we can get together and discuss if you have any questions. And know that we're all of the faculty, we're all here to help. So if we go through this and you have questions, feel free to ask. If you're not speaking at the moment, if you'll, it looks like most of you already did. So if you'll just keep yourself on mute unless you have a question, because I know a lot of you are multitasking, you have animals, you have kids in the background, you have a lot going on. And so just to try to help decrease any background noises, and I'll apologize in advance. I also have 3 dogs, and so you may hear them at some point. So I'll try my best to keep them at a minimal. All right, so today I'm going to start with the diabetes presentation, and then we will, it's not going to take 3 hours to cover that. And so so there's a couple ways we can divide up. So we'll have today and then next Monday and Wednesday. So there's a couple ways we can divide it up, but I'll get through diabetes today. And then if your brains are done by the time I cover that, then we'll just be done. And if you guys want to keep going on another topic for a little bit, we can. So we'll see how that goes once we get to that point. All right, so I'm going to try to record. I'm not making any promises because on Zoom, I've had some challenges with the storage space. And then it reloading later. So if you want to record, feel free, just like we would in class. If you want to record the audio, like on your phone, or you somehow record the audio, then feel free to do that yourself as well. Again, I'm going to try, but I don't know if it's going to cooperate with me today. All right, I will share my screen and flip over to the presentation here.
Huh? I gave it the Leprechaun last night. Oh, that's why. Yeah. I knew there was something
Darda,
different.
can you mute your chat, please?
Yeah, if you're not on mute, if you'll go ahead and mute yourself, that would be wonderful. I'm going to try to take that down a minute. So there's a question of giving permission to record. Bear with me a minute. Let me stop sharing for a minute. I haven't done that before on here, so bear with me. All right, so I don't know how to give permission for you guys to record on Zoom. I'm just being honest. I don't see that setting anywhere. Allison, I know you're on here with me. Have you ever encountered that setting before?
I think you have to do it when you set up the meeting planner.
Okay, that's what I was wondering because I don't see where I can change any of that now.
Yeah, when you set up the meeting planner, I think that's one of the choices that's given.
Okay, so I can try to do that for the next meetings and go in and change those. So what I recommend to the group, again, I'm going to try to record it, but as a backup, if you want to use, if you have tape recorders that you use in class, if you have your phone that you did the audio recordings, you're welcome to use those too. Sorry, guys. And I know there's been mixed information going out about recording on Zoom because everybody's on Zoom and you're in your homes. And so there's been mixed information about privacy laws and whether we should or not. And so just know that there's a lot of controversy about that right now. So when I start doing the presentation and I start recording, I'm not going to be able to see. I'm just being honest. I'm not going to be able to see you guys because I'm going to be looking at my presentation. So since I'm recording, if you want to turn the video off during that part and then turn it back on when we come back together, I'm okay with that. Since I'm going to record it. So I'm okay with that if y'all want to do that. All right. Just type in through the chat or unmute yourself and holler at me if you have a question as we go along. Okay. All right. Now let's see here. All right, so I know that I've got it recording and then I hope it'll cooperate and be able to upload. All right, so today we're going to talk about diabetes. This just kind of starts off with just a picture of your pancreas. So this is the organ that we're spending a lot of time talking about and kind of the description of it. So just a little picture there for you. And well, now if I can get the computer to work. There we go. All right, so diabetes. Certainly diabetes is a major health problem with many complications. Some of your major complications include hypertension, hyperlipidemia. Then you have complications of diabetes. And so those complications, the major ones that you kind of hear the most about are, it is the leading cause of blindness, end-stage renal disease, and then foot and leg amputations. So I think for many of you in the hospital and your clinical settings, you're going to encounter a lot of these throughout your time, either in clinical or if you end up med-surg in some of the areas in the hospital, then you'll encounter this pretty frequently. There's a lot of people who have undiagnosed diabetes that either are not going for regular checkups, haven't been to the physician lately, and do not know that they have diabetes. So the metabolic disease affects the glucose regulation and then your insulin regulation too. So kind of the pathophysiology with it, all types, a major feature is it can cause hyperglycemia. So the high blood sugar or high blood glucose, you hear different terminology for that, resulting in a problem with their glucose regulation. It includes the reduced insulin secretion or reduced insulin action. So the insulin may be secreted by the pancreas, but it's not acting. And so then you have a lack of insulin or a lack of the action of the insulin. And we'll get into more detail with that too. So your pancreas is responsible for your endocrine function and regulating your blood glucose levels. And so you don't have to know this for my test per se. There may be a board question later, but so your pancreas contains the islet of Langerhans. It's like this million cells, little glands that are in there located in the pancreas. So it's all of these cells working together, little glands working together. So there's two types of cells. This is important to know because later when we talk about medications, the medications are going to focus differently. So some of the medications may focus on the alpha cells and some of the beta cells. So your alpha cells secrete the glucagon, and the glucagon is that counter-regulatory hormone that prevents hypoglycemia by releasing the glucose. And then your beta cells produce the insulin and amylin. I'm more focused on the insulin though. So your alpha secretes the glucagon and your beta produces the insulin. So alpha produces sugar, your beta, the insulin, and then those then regulate. So your insulin is excreted daily directly into the liver, and it kind of goes in a two-step method. So low levels are excreted during fasting. So throughout the day, or throughout the night, you're not up eating at night unless you're like my 16-year-old who has a midnight snack every night. Then that is secreted kind of throughout at low levels. And then after eating those meals, it sends out larger levels. So there's kind of two ways that it sends that out. So your glucose regulation and homeostasis. So your glucose is the main fuel for all of your CNS cells. So it's what keeps all of them going. So when they don't have that sugar, then they start to slow down. Your central nervous system cells are not able to store very much glucose, so they need that continuous supply. Several hormones and different organs play a role in regulating that. We're going to talk more about that. And so normal glucose level would be 60 to 150. That varies slightly in different agencies, but as a whole, kind of that 60 to 150. And then your insulin keeps the blood glucose levels from being too high. It also reduces fat breakdown and then protein breakdown. So your proteinolysis is the breaking down of those proteins. So this is kind of just the high level for now, and then we're going to start to dive deeper into this in just a little bit. I'm not going to read everything on this slide, but this is a good slide just to go back and review, because all of these terms are terms that you're going to, if you don't already know these terms, are terms that you're going to want to know throughout nursing and as you're going into your NCLEX. So the absence of insulin creates decreased, and I'm going to get tongue-tied on saying half of these myself, glycogenesis. So genesis is usually the building up, so the glucose to glycogen, and your lysis is the breaking down, glycogen to glucose. So your absence of insulin, you'll have decreased breakdown buildup from your glucose to glycogen, and an increase of the breakdown glycogen to glucose. An increase in the breakdown of your triglycerides to glycerol and fatty acids. The term on here that is probably going to be focused on the most is the ketogenesis. And so that's the formation of those free fatty acids. I'm sorry. Well, probably the last one, the breakdown of your protein. Breakdown of the protein is one we're going to talk about more. We're going to talk about that with diabetic ketoacidosis, and we're going to talk about kidney function. So these are all just terms that when you see these on a test, you're going to kind of want to know what they are. I'm not going to say, what does this term mean? But you may, on an NCLEX question, you may see some of these terms, and then you're going to have to know what they do in order to answer those questions. Does that make sense? Okay. Oops, I think I went too far. Okay, so more with absence of insulin. So think of your pancreas stops either producing the insulin or the insulin stops acting. So you end up with hyperglycemia, so high blood sugar. You guys, I know you just did fluid and electrolytes and a lot of hyper and hypo. So hyperglycemia, so high blood sugar, is going to cause further fluid and electrolyte imbalances. And then think of your 3 Ps, so polyuria, polydipsia, polyphagia. I know that you guys are new to my teaching style. I try to highlight areas that you're going to need to know. You're going to need to know this slide. So hyperglycemia and your 3 Ps. These are your 3 classic symptoms of hyperglycemia. So they're going to have excessive urine, excessive thirst, and they're going to be hungry all the time. And just remembering those 3 Ps is going to help you with diabetes. So then your fat breakdown, releasing the fatty acids. So this is where you get the ketone bodies. So this gives the backup energy. But then when you have the ketone bodies or the ketones, that is the abnormal breakdown that collects in the blood, which can lead to metabolic acidosis, which is also known as ketoacidosis for your diabetic patients. And we're going to talk a lot more about diabetic ketoacidosis. Absence of insulin also, you end up with dehydration, or can end up with dehydration, hypovolemia, poor tissue perfusion, hypoxia, lactic acid is increasing, and then causing even more acidosis. And so with all of these, you think of poor tissue perfusion, hypoxia, think of all of these, and then you add in hypertension, or you add in your kidney function. So with hypoxia, poor tissue perfusion, your kidneys aren't getting the perfusion. So this then has a domino effect impacting many different organ systems as well. So continued with that absence of insulin, that excess in your acid is caused by that lack of insulin. And so I don't know how much you guys, well, I'm sure you guys talked about the hydrogen ion and carbon dioxide levels. So again, that metabolic acidosis when you guys went through fluid and electrolytes. So this then triggers the brain to increase the rate and depth of respirations to blow off that CO2, known as the Kussmaul respirations. Kind of a classic symptom with your diabetics is this, it's called it's acetone is exhaled, and then it has this rotting, kind of nasty, fruity odor to their breath. So when they breathe it out, it's kind of a classic symptom with this, and that smell is. So with metabolic acidosis, they're going to have their pH is going to be low, their bicarb's going to be low, and then they're starting to try to compensate for that, and then you could end up with the respiratory alkalosis. So again, that lack, kind of keeping along with that lack of insulin, can then cause the potassium to be depleted. And so the potassium, so think you have your serum potassium, you have your potassium in your cells, you have it in your blood. And so depending on your potassium level that you actually get is going to depend on their hydration status too. And we're going to talk a lot more about that too. Usually their potassium is going to be low, but it could be high depending on their hydration status. But typically in these patients, it'll be low. All right, let me pause there. Any questions so far?
So it's saying the potassium levels could potentially be high, but you would definitely see a low potassium in these patients with diabetes. So once, not just diabetes. So great question. Let me clarify that just a little more. So in the management of diabetes, you end up with different complications. And so one of those complications being that acidosis and the metabolic changes too. So that's when, if it's not managed well, you'll see that we're starting to get into some of the complications. And so that's when you'll see the changes with the potassium levels. If it's managed very well, your potassium should be normal. So great question. So what I've gone over, and I'm going to go into that in more detail here in just a second. Let me see if anyone has sent me any questions here. Well, where'd it go? I'm trying to see if anyone sent anything on the chat. So what I've covered is just kind of like, think of that like a simple, well, it's not simple because there's more to it. Think of that as kind of the lead up to the bulk of what I'm going to get into. So from here, I'll go into so those absence of insulin slides are not normal, okay? Now from here, I'm types of diabetes, and then I'll start going into more complications of diabetes. So everything that I just touched on, I'm about to go into even more detail. Does that make sense? Okay. Okay, so different types of diabetes. Does anybody know somebody with type 1 diabetes?
Yes.
Okay. How old were they when they were diagnosed with type 1 diabetes?
5, I believe, young, a child.
Right.
My son has type 1 diabetes and he was 2.5.
Okay. So the thing to remember with type 1, absolutely correct in what everyone is saying so far. So the thing with type 1, usually that is diagnosed at a fairly young age. So it's usually caused by an autoimmune disorder with the pancreatic, so it causes beta cell destruction. Sometimes it's diagnosed around an illness because that's kind of what triggers that autoimmune disorder. So sometimes it could be early, like, I don't know who said, around 2. Sometimes it could be a little later. And so there's this autoimmune disorder that's there, and then something triggers that. So usually onset is less than 30 years of age. This is based on that autoimmune. So it's not based on how they've taken care of themselves. So these patients are usually not obese. They could be very healthy. It's just something with that autoimmune and those beta cell destruction. So these patients become insulin dependent because the body is not producing insulin. If it is, it's in very, very small amounts, so it's not enough. So think of it as either very, very minimal insulin production that's going on or no insulin production at all. So these patients become insulin dependent. So not your oral medications, but insulin.
And then your symptoms with this are abrupt onset. You have that thirst and hunger, increase urine output. So the 3 Ps, because the blood sugar's high, because that insulin's not there to counteract it. And they're usually encountering some weight loss.
Miss Lynn,
Yes.
you talked about it being triggered by illness. What kind of illness?
So it could be, it could be of something virus. It could be, it could be really anything. It doesn't always have to be triggered by an illness, but it could be. And it just means that something triggers the immune system, and then those beta cells become destroyed. So then they're not producing insulin. So often is triggered by an illness, but doesn't have to be. So I like these slides, and I try to use these throughout my presentations just to help show a quick little summary and to help, I know everybody learns differently, and help give a visual kind of what's going on with the patient at the time. So this is your type 1 diabetic. They are having those 3 Ps, the polyuria, polydipsia, polyphagia symptoms, and then they're diagnosed with type 1. And here's some other symptoms that they've had. So weight loss, fatigue. Sometimes it could run in the families. Maybe they've passed it down. And then usually they're younger in age when they're diagnosed. So type 2 diabetes is a progressive disorder where you have the insulin resistance and then the decreased beta cell secretion of insulin. So the beta cells are there, they're just not working as well. So type 2 diabetics are usually diagnosed later, a little bit later in life. Onset's usually pretty slow. A lot of them are overweight, obese. Not all, but many are. And then about 20 to 30% of these require insulin. And we're going to talk more about medications in a little bit. And then some of these symptoms. So again, they'll have thirst, fatigue, blurred vision. They may have more progressive symptoms when they're diagnosed because it's a slower onset. It may have been dealing with it for a little longer period of time. Some of these will have it uncontrolled and they're just not seeking medical attention. And so some may have more symptoms when they're first diagnosed because it's gone on for longer and it hasn't been well managed. So your type 2 diabetics can have what they call metabolic syndrome. And so this is that abdominal obesity. So you'll see with that, some of these patients carry that weight right around their abdomen. You'll have hyperglycemia. Oftentimes hypertension and hyperlipidemia go hand in hand when they're diagnosed with type 2 as well. And then when all of these are present, then that risk for cardiac disease goes up even more. So some other risk factors, if they have a parent with diabetes that developed later in life, obesity, physical inactivity, certain race and ethnicities can play a role. They just have a higher incidence. History of gestational diabetes, so we're going to talk about that in just a minute. Polycystic ovary syndrome, hypertension, and metabolic syndrome. So here's kind of the picture of your type 2 diabetic. So, she's sitting around, kind of overweight, which is maybe, I feel like this is a picture of me during the pandemic right now, just sitting around, eating chocolates and not doing very much. And so probably has your 3 Ps, your polyuria, polydipsia, polyphagia. Your type 2 diabetic can they may have some nocturia where they're getting up at night. That could also be with your type 1. Let's see, if they get any cuts, wounds, it takes longer for those to heal. They may start having visual changes. We're going to talk about lab levels in just a minute. So your A1C and fasting blood sugars. And then your triglycerides, sedentary lifestyle. So most commonly, these are diagnosed at least after 35, but more commonly even up into the 50s.
So you're going to have the 3 Ps for both type 1 and type 2?
Yes.
Okay.
Yes. So that would be for so think of those 3 Ps as just a lack of insulin and high blood sugar. So there are more symptoms of hyperglycemia, and you can have the hyperglycemia with type 1 and type 2. So the difference in your type 1 and type 2 is really, so the type 1 are diagnosed earlier because those beta cells have been destroyed. And usually the beta cells are not producing insulin at all. To where your type 2, the body has created, the body's kind of created it because we haven't taken good care of ourselves. Then those beta cells are there and there's still insulin being produced, but it's just not being used very well because we've kind of hurt our body over the years. So think of it like that. So you still have similar symptoms, same symptoms, just a different way to get to that point. Does that make sense?
Yes.
Okay. And then here's a picture with here's a picture that kind of depicts the different types here at the top. So type 1, type 2, gestational, which we're going to talk about this. So this would be during pregnancy. There's a few other types. We don't really get into these very much. Mainly, I want you to focus on type 1, type 2, and then a little bit on gestational. And then, so this is supposed to be like a picture of your pancreas here. And so there's either decreased or no insulin secretion. So that's how it's usually diagnosed as either the type 1 or 2. And then all of your complications from it. So short-term and long-term complications. And then the assessment, what you're going to see in this. So this is as you're studying, this is a really, really, really good slide to study that kind of has the whole picture in one slide with just some really good information there. All right, so your gestational diabetics. Has anyone been pregnant and had gestational diabetes that is willing to share that they had it?
I had it.
Okay, and so how was that diagnosed when you had it?
So I did the glucose tolerance test, where you drink that nasty drink, and then I had to go back and do it a second time.
Right.
And then that's when I was diagnosed.
So what was your blood sugar when they did that? Do you remember?
I can't remember. I know the first time it was like right at the mark.
Okay.
Like I was just a little bit over. And then the second time, like my first 2, I passed. And then like I think it was my fast. Yeah, my last one, I feel.
Yeah. So gestational diabetes occurs obviously while somebody's pregnant. So this would be the women, of course. So it's diagnosed with the glucose tolerance test. So for any of the women who have been pregnant, they make you drink this nasty. I've heard very few people like the taste of it, but I thought it was kind of nasty myself. This nasty sugary drink, and then they check blood sugars at various times to see then what your blood sugar is. And they have normals that it should be in, what range it should be in. And then if you fall higher than that range, then that's when you're diagnosed with gestational diabetes. So your insulin's not there to help bring that level down. So there's a couple things you worry about with gestational diabetes. So you worry about the baby and the mom. And so they expect those insulin requirements to increase during pregnancy because that mom is supporting themselves and the baby. So that's a normal expectation for that to increase. But it's how the body counteracts and handles it. Is the blood sugar and the insulin, is it managing it well or not? And so then when the blood sugar is going too high, that's when they have the gestational diabetes. So your medication of choice for your gestational diabetics is usually insulin. They try to do vaginal deliveries if they can, but they're trying to do that with everybody unless there's a need not to. And so you're going to watch for hypoglycemia during postpartum, and you're actually going to watch for it in both the mom and the baby. And then after the pregnancy is over, after delivery, then the insulin requirements will decrease and go back to normal. So usually that the female, the woman who's pregnant, usually the body adjusts, it goes back to normal after pregnancy's done, after delivery, and they go back to their normal diet and everything. Now, these patients are a higher risk to have type 2 diabetes later in the future because they've already had this during the pregnancy. So the body was stressed with the pregnancy, and that was how the body responded. So there could be a higher incidence of developing diabetes type 2 later in life. So with this, they'll look at their diet. They'll do certainly teaching for insulin and how to give it, how to monitor their blood glucose levels, and then dosing for the insulin. They're going to have some extra. You're going to learn more about a biophysical profile later. Just know with this that after starting at about 28 weeks, they're going to start looking at the baby a little bit closer. That's the important thing to know. And then they may do an echo. They may do more ultrasounds just to check on the baby. So around that 20 to 22 week mark, and then later. So you don't have to know those in detail. Just know that they're going to be watching the baby a little bit closer to see if there's any complications that the baby's having. And then there's some secondary conditions that can cause diabetes. So some of these conditions could be Cushing's syndrome, your hyperthyroid, long-term use of parental nutrition, and then there's different medications that can cause it. So your steroids is the biggest one. So steroids can cause that. If you have like a COPD patient who's on steroids for a long period of time, then they could develop diabetes. If you are on steroids short term, it could make the blood sugars go up temporarily, but usually after stopping it, it's going to be back down. So it's those patients that are on long-term use of steroids. And then there's some antipsychotics and a few other medications that could cause it. But your biggest medication that's going to cause a high blood sugar is steroids. And so that may be something you want to know in the future as well. And you'll probably see that. You'll probably see that in clinicals as well, and depending on what unit you're into. All right, so assessment for diabetes that you're going to look at. Of course, you're going to look at their weight and their weight history. Have they gained weight lately? Have they lost a lot of weight? Usually it's going to be a weight gain with these patients. And it's usually over a period of time. Their age, vital signs, women, and have they been pregnant, and did they have gestational diabetes during that pregnancy? The other thing I meant to say during gestational diabetes, usually this causes the babies to be large when they're born. And so it's not uncommon for these babies to be born weighing greater than 9 pounds. If you have a female that you're doing an assessment on, it's also good just to know, how many children has she had, and were they all, like, what's that history? Were they all like over 9 pounds? Were they all big babies and she was just never diagnosed with gestational diabetes? Or were they, all, 7-8 pounds, then that's a good healthy weight. They're all pretty large. You start getting those bigger, like you hear those stories of 10, 11 pound babies, and was never diagnosed. Then that's when you may want to question, maybe there was a little potential for that in the past as well. So is this person fatigued? Remember your 3 Ps, polyuria, polydipsia. Sorry. And then polyphagia. Have they had recent infections? What's their sensory abilities? Sometimes they'll start to lose some of the touch in their hands, especially in their feet. How are they coping? And then any educational needs when doing your assessments. So different, different lab values that you'll be looking at. So their fasting blood glucose level, and then here's your ranges, your glucose tolerance test. So this is the 2-hour result. Then there's other time periods that they look at too. So this is the 2-hour plate, normal ranges. And then your glycosated hemoglobin, which is also called the A1C. So we're going to focus mainly on the blood glucose and your A1C. And I've got a chart that we'll talk about here in just a minute too that talk about these. So for your A1C, this measures if the diabetes, how well the diabetes is being controlled. So if it's being controlled well, then usually they're going to have, if they're already a diabetic, then you want that level to be in the 6.4 or lower. Preferably even under 6, but at least in one of these 2 ranges. If they're above 8, then it shows that over the long period of time that their diabetes is not controlled very well. So this is helpful in diagnosing in the beginning, and then for managing the diabetes as they have it too. Here's some more lab values. Your fasting plasma glucose, other plasma levels, the oral glucose tolerance test. So on this screen, the ones I want to focus on would be how do you know what the kidney function is doing? And so that's going to be with the urine test or kidney labs that are going to talk more about your kidneys. So in your diabetic patients, they're checking the urine pretty frequently. And in that, you're checking to see if the glucose is spilling over into the urine. It means that the kidneys are not able to filter it out as well. And then if you have ketones spilling over, ketones are an even higher indication about your renal function. So you may have some glucose, but that could be stress related. That could just be, there's something else going on. It could be temporary. Your ketones, when your ketones are starting to spill over, this is sending up some kind of red flags that there's something else going on with the kidneys. So I would go back and see what is their blood sugar. If this happens, I'd go back and I'd want to check their blood sugar level. And I would also want to check their kidney functions, their albumin and their serum creatinine levels. Because if they're spilling ketones and they have a high blood sugar, then they have flipped into that area of emergency that you want to start looking at that. And so, we do those urine dipsticks up on the floors at the hospital, and sometimes we just look at those and, toss them aside. So this in your diabetic patients is really what you're looking for, those ketones. So this is a good little chart to kind of see how well patients with diabetes are managing long term. So if their A1C comes back and it's at an 8, then what that correlates and what that kind of means is that on average their blood sugar has been staying around 100 in the 180s. And so if they come back and their A1C is a 6, then it's saying that their average blood sugar is around 126. Now, can they have some highs and lows? Absolutely, they can. But overall, what this is kind of where that A1C will come back and saying how it's been managed over a long period of time. So certainly if you have someone who comes back with an A1C of 12, that's around that 300 mark. And so that means they're living with a pretty high blood sugar pretty regularly, which would not be good. So this chart kind of gives you a correlation of when when you get that A1C result, what on average is their blood sugar, because you're just getting a snapshot, one picture in time with their blood sugar. But your A1C is going to tell you how they're managing it over a long period of time. Does that make sense? Okay, I don't hear any questions. So far. So different medications that can impact your blood sugar. This is a big list of medications that can decrease your blood sugar and a list that can increase it. So if somebody is kind of experimenting with some drugs on the side and not telling you, or alcohol, then that can also increase their blood sugar. I would say the medication that you're going to encounter the most, that's going to have the biggest influence, again, is going to be your steroids, and it's going to cause that blood sugar to go up. So your goal with any of your diabetic patients, once they're diagnosed, is to prevent complications. So you want to try to have them manage it well, and then you want to prevent complications. So preventing injuries, education for nutrition, how to check their blood sugar, how to take care of their monitor, how to clean their monitor, when to seek medical treatment if it's not in range, and then recommended activity levels, their optimal weight, how do you help them solve any of those any problems or any barriers. Can they afford their insulin? Can they afford their medications? Maybe that's why they're not taking them, because they can't afford it. So how do we help with, what other resources do we pull in? And so kind of your 3 areas to focus on for management of diabetes is going to be exercise, diet, and medications. And I'm going to stop sharing my screen for just 1 second. I have a couple of questions. So one question, steroids can cause a decrease and an increase. So your steroids will cause an increase in the blood sugar. Did I say decrease somewhere? If I said decrease, that's not what I meant. Usually taking steroids will cause an increase in your blood sugar. Did somebody say something? I'm sorry.
Ms. King.
Yes.
So I'm looking at slide 23, where it has cause decrease blood glucose, anabolic steroids.
Hang on, let me get back to that slide. Okay, I see what you're looking at. Just take that one off, ignore that one for now, because most of what you're going to be dealing with is your corticosteroids. So that's a different type. So I'm sorry that I see where that could be confusing. Just focus on the increase in blood sugar with your corticosteroids. Sorry about that.
Thank you.
Thank you for, hold on. Thank you for asking. All right, let me Can everybody see again? Okay, so some different nursing diagnosis that you'll look at with diabetes would be risk for injury related to hyperglycemia, potential for impaired wound healing. So there's going to be a lot of risk for injury for different things. And so this is going to focus like on those nerve endings and not, those nerve endings not feeling as well and decrease blood flow in circulation. So that's going to that can cause problems with your eyes, the nerves, and the kidneys. Potential for hypoglycemia because of so your risk for hypoglycemia is going to come from the treatment. So your insulins and the oral diabetic medications certainly will create that potential for hypoglycemia. The potential risk for diabetic ketoacidosis and hyperglycemic hyperosmolar state. We're going to talk more in depth about those complications too. So just a list of nursing diagnosis if you want to review that. All right, so these next couple of slides are going to go into medications. And this first couple of slides are for type 2 diabetics. So remember, your type 1 are going to be controlled with insulin. So your type 2, these on this slide are orals. So your oral anti-diabetic medications. And so there's different types. Remember back early on, I said something about your alpha and beta cells. And so these different types work differently. So you may see a patient on the glipizide, and you may see a patient on metformin. And so those work just those two work similarly. But let me go to the next page. So these, let me go back. So you could have the glipizide and metformin, and those do work similarly. And then you could also have a patient take, on the, the Precose. And so these work a little bit differently. So this alpha, and I'm not even going to be able to pronounce the word, but your inhibitors here, these prevent after-meal hyperglycemia by inhibiting enzymes in the intestinal tract. So this works completely different in a different manner than these that are working from your beta cells. And so you may have a patient with different medication regimens, knowing that some of these work similar and some are short acting, some are long acting, some are the extended release, and then some are working even in the gut and the intestinal tract. And so I would look and read over these slides. Again, I'm not going to read them all to you because you guys can come back and read this yourself too. But these are all oral. So kind of high level, these are all oral medications. All of these, the biggest side effect you're going to be monitoring for is hypoglycemia. Because even though they all work differently, they're all doing the same goal. They're all trying to decrease the glucose. So biggest side effect for all of these is your hypoglycemia. Same with these. These work, some of these work a little differently, and then you could have combinations of the medications too. So same thing, they're all trying to decrease the blood sugar. So biggest side effect is hypoglycemia with all of them. So then your insulins. What route is your insulin given? Mainly. Anybody want to answer?
Sub-Q.
Sub-Q mainly. We're going to talk about that too. So your type 1 diabetics are going to be on insulin, and then some of your type 2s are going to be on insulin. So usually your type 2s, they're going to try to manage with the oral medications first. And if they can get the right balance with the oral medications, great. But if they can't get the right balance with the oral medications over a period of time, then those type 2s may then advance to needing insulin to manage. With your type 2s, they're going to try to manage those with the oral anti-diabetics first and diet and exercise. So they're going to try that, that trifecta approach there, the 3 diet, exercise, and then the orals. And if they can't do that, then they'll manage that with insulin. So there's different types of insulin. You have rapid, short, your intermediate, and your long. The measurements for insulin is always in units. And there are some of these that can be combined as well. So we'll go into that. I'm going to pause just a second. I think I have another question. So the names for the medications, that would be your, let me go.
Metformin.
So I think they've started doing like on, okay. Can y'all see my screen again?
Yes.
Okay, just making sure. I'm trying to go back. So I believe the NCLEX is going, like, to me, these are your generic names, so your trade names. I believe that's what the NCLEX is going with. So like your trade names for medications. It's a great question. Okay, this would be a great graph to memorize because you're going to be dealing with insulin at some point if you haven't already. Is anybody already given insulin?
I have before.
Yes.
But before, yes.
Okay, so this is going to be a great little graph to know. And so in this, let's see, so your onset, peak, and duration. So your peak is the one that you're going to watch for the most complications during. So this is when you're going to watch for the highest incidence of hypoglycemia, is during the peak time. It can happen during all of it, but I guess the prevalence for it is the highest during the peak time. So write down this slide so that you know that one. So insulin is derived, it comes from animals or synthesized in the lab. And so if you don't know, insulin was made from like beef or pork. And so there was different periods of time where either like with mad cow or problems with the pork, that at times they had a hard time getting insulin. That hasn't been the case in quite a while. So right now we have an abundance of it. So different types of insulin. So your rapid acting is ultra short, quick. So this is the Humalog. Then your regular insulin is a short acting. It's clear. This is the only insulin that can be given IV. And so that would be used to treat your diabetic ketoacidosis. So we're going to get into that in a little bit. And then your intermediate would be your NPH. This one's going to have that cloudy appearance to it. Has anybody had to mix 2 insulins yet?
Yes.
And so what order did you mix those?
Do clear to cloudy.
Very good. Clear to cloudy. And then your long acting would be like your Lantus. So there's not a peak time for your long acting. It should have that constant effect. So it's usually like every 24-hour dosing. And then Levemir is also that long-acting 24-hour constant effect. And this would be one that would not be mixed with other insulins. So then there is sliding scale insulin. I probably don't go into this as much as maybe what I should. And I probably don't focus it on this on as much as I should. And I'll tell you my reason for that, because I feel like every agency does sliding scale insulin a little bit differently. So whether you're at a hospital, whether you're doing clinical at I don't think we go to any nursing homes, but I feel like everyone does this just a little bit different. And there were times where different physicians did it differently. I think it's gotten better to where it's more agency specific now. But the thing, and some people have gotten away from sliding scale, some are doing it. And so it really varies depending on, it just really varies depending on where you're at. But the thing to know with sliding scale insulin is you're going to check a blood sugar, and then depending on the orders or the protocol that agency has, then depending on the response you get with that blood sugar, then you're going to give whatever regimen they've ordered. So that could be, and there's many different regimens. So that's the other reason why I just didn't want to get too in-depth into this, because I don't want to confuse everybody. But they look at, so in this regimen, they look at the carbohydrates. So they're going to try to help control with diet. So they're going to have a preset number of carbohydrates with each meal. They're going to give that bolus right before they eat, and then before bedtime. So I don't do a lot with the sliding scale. Please read through this so you understand it and you know it for clinical applications and you know it for future applications. But I don't focus a lot on this because I feel like there's so many variables to this. So I just want to put that disclaimer there. So for my purposes, focus on, of course, you need to know your medications. So yes, that is a lot of oral medications to know. You don't exactly have to know how they all work, but you need to know the medications. Know that they all work differently. That's why patients may be on multiple medications. You want to know the biggest side effects and what you're looking for, what you're monitoring. And then you want to know your insulins. You want to know the different types of insulins, how they're given, how they can be given. If you're mixing them, I think we'll go into that maybe even on this next slide. So focus on overall medications versus the sliding scale, and then hopefully that'll help you.
Do you have to know the peak and onset?
Yes, I would know the peak and onset. So usually when you're given, or well, not usually, when you are given insulin, so your insulin syringes are either going to be 100 units per ml or 500 units per ml. So depending on dose that you're giving of insulin will depend on which syringe you're going to grab, because it's going to have different concentrations. And so you'll work with, especially when you're in clinical, you'll work with your instructors and you'll be able to see the difference in that. I know in the hospital, at least my last clinical in the hospital, they're doing it as much as they can already drawn up. So like in pre-filled syringes is how they're trying to do it to decrease any medication errors. And so really look at those syringes when you get them. They're a little different. That's why they're insulin syringes. It's the only thing you're going to use them for is insulin. And so look at the units on there and you'll be able to kind of gauge and see that a little bit better. So your insulins are given subcutaneously that we talked about. Your regular insulin can be given IV. And then your regular and rapid can be used in the continuous insulin infusion pumps that go sub-Q. And we'll talk about the insulin pumps in just a minute too. So anytime you're given insulin, they're trying to plan that around their lifestyle, their meal planning, exercising. They have to have some kind of insulin available to the cells when glucose is present in the blood. So you're trying to plan that. So if you have a patient who's a big runner and they're exercising a lot, you're going to want to be careful because increased exercise can also cause hypoglycemia. So especially in your type 1 diabetics, if you have a slender, athletic person who is very athletic, they're into a lot of sports, they're exercising, maybe they have football practice every day, or maybe they're a cross-country runner, maybe they're just very athletic and a lot of exercise. You're going to do a lot of education with them on their diet and making sure they're eating enough and they're getting enough intake of sugar too. And something to, not just the simple sugar, but something that'll last them a little bit longer. And so they're going to teach them to eat before doing that exercise so that they're not bottoming out right after that exercise. So then there's different regimens for your insulin. So you have your single dose daily. So these are usually your longer acting, or a combination that may have the short and immediate acting. Multiple components. So this kind of breaks it up throughout. And then there's some of those intensified regimens. Some of these, let's see, some of these will have different boluses in there too. So I just share this so you know that there's different ways. That's why I feel like no two patients look the same when you have your diabetic patients. And so there's multiple ways that you can kind of treat these in different regimens that can be on. So if you're mixing insulins, so say you're mixing your intermediate and your short acting, you're going to drop the clear before cloudy. And so let's see, does it go into, yes. So this one, know this, especially for your clinicals. But when you're mixing those two, you're going to draw up your clear before your cloudy. But you're going to clean both of them. You're going to inject your air into which one first?
Cloudy, going to be the most.
Do what?
Cloudy.
Cloudy one.
Yes, yes, yes. Inject your air into your cloudy first, and then inject your air into your clear. Draw up your clear, then you're going to draw up your cloudy without injecting any air. Then you're going to give it to your patient. So that's kind of the process. This is the process if you have to mix those for drawing it up. Somehow I have red on my screen and I have no idea why. Do y'all see this red line?
Yes.
I don't know what I did. Okay, so with your insulin, you're also going to rotate your sites. You're not going to massage afterwards. So there's some medications that you massage the site afterward. You can apply pressure. Some may say it burns or stings. So you can put pressure to help it to feel better. You're also going to want the dose you're giving to be warmed up to room temperature. So maybe they're storing it in the vial in their refrigerator. So you're going to want it to be warmed before giving it. So make sure to rotate the sites so that they're not getting any irritation in the locations there. Do not massage. And then if that vial that they're storing ends up frozen, some refrigerators work better than others, then you'll have to discard that and get them a new one. So here's some different subcutaneous sites. So you have the back of the arms, this lower back area. A lot of patients really prefer the abdominal areas or the thigh areas, and you can also do the arm areas there as well. So that's kind of your various sites for your sub-Q. So some of your patients will have a continuous subcutaneous infusion. So this is not IV. This is just as if you were giving the sub-Q injections, but it's in a pump and it's set. And so it's a continuous infusion. So it's an external pump. You see some of them carrying this. Most of the time the patients I've seen this are your type 1 diabetics that have no insulin production whatsoever. And so this can give that basal dose that kind of keeps it on board all the time, and then they can do bolus doses at meal times. So this is usually done with rapid insulin. So when you read questions and you're looking at information, don't confuse yourself. So your continuous subcutaneous, so subcutaneous is the key, infusions. This is going to be your rapid acting insulin. Now, if I tell you it's regular insulin and it's continuous, where is that probably given?
Is it IV?
IV. So your regular is the only one that can go IV. And then your rapid would be in your subcutaneous pump. All right, so with that, they're going to do frequent monitoring of their blood glucose. Certainly your goal to keep it in normal limits, as normal as possible. Urine testing, I have on here, urine testing is not reliable because I don't want you to depend on that alone for glucose and spilling. Now, if you do a glucose or a urine test, if you do a urine test and you have those ketones, that should send off a red flag to you, and you should start looking for other things. Do they also have a high blood sugar level? If so, then that should trigger you to start, then that's going to alert you to diabetic ketoacidosis, and you're going to start looking at some other things too. So yes, I have on here urine testing is not as reliable. And just to clarify again, what I mean by that sense is if a patient's spilling glucose, for example, that could be stress related or illness related, but then it could go back to normal. If a patient is spilling ketones in their urine, you want to take that serious and you want to look at any other symptoms. Now, the test may not be reliable, but you want to then follow up and see if there's anything else that's going on with them. So don't just totally dismiss it because I said it's not reliable, is the point I'm trying to make. So a lot of your patients are going to do the self-monitoring with blood glucose machines. They'll come up with some kind of regimen to try to decrease the dangers of hypoglycemia. So you don't want them having hypoglycemia. So like I mentioned, in those that are exercising a lot, so you're like your type 1 diabetics, maybe it's a young teenager or a young child who's out playing sports. So you have to find the right times to monitor to help decrease the hypoglycemia chances. And then making sure that they have, there's so many different machines out there. You want to make sure they have a good pump and I don't know why. Sorry, guys. I don't know why. Somebody sent me a chat. Let me see if I stop sharing, if then I can see it. I'm going to take a break here in just a few minutes. I can't. Let's see. Bear with me. I think I'm almost. Yeah, in just a few slides, I plan to stop for just a second. Okay, let me get back to sharing my screen here. Okay. So in that monitoring of the blood glucose, so certainly they're going to need the lancets to do the finger stick. They'll need the test strips and then the monitor. So you have some patients, if they have a higher hematocrit, could have falsely low readings. So just something to keep in mind. And then there's some medications that can cause some inaccurate results. And then make sure that the test strips are compatible with that meter. And then there's some that even have like the little chip that has to be changed each time as well. Nutrition, they're going to follow the Diabetic Association guidelines, trying to make sure that they're getting enough carbohydrates and achieving all of their other healthy aspects of life too. So they're monitoring their blood pressure and glucose levels and nutritional levels. A lot of times they're going to be referred to a dietitian to help with carbohydrates in their diet. Some are still going to want to consume alcohol, so how can they do that in a safe manner? And so a dietitian can help work with them so that they can monitor all of those things. And then the carbohydrate counting, you'll hear that frequently. And I am going to tell you, by far, I'm not an expert on carbohydrate counting and diet. That is where we're going to refer to our dietitians, but they're going to look at the carbohydrates when they're, so think diet, exercise, and medications. So those three are your key indicators and key ways to treat and manage. These are some examples you would use for carbohydrate counting. And then exercise. Helps in that with the weight control. It also helps with the insulin sensitivity. And so all of those are going to play factors into the management of that. You want them to kind of avoid extreme hot or cold temperatures. And we'll talk about that more in detail. And then have them carry simple sugars with them. Especially during times of exercise, they're going to want to eat that snack beforehand, but then carrying simple sugar with them so that if they feel hypoglycemia coming on, they can treat that. And this is just a good little slide about exercise. And then I think from here, this and complications. So here, this is where I wanted to get to, and we can stop for just a little bit and take a break. Why don't y'all take about till let's see, I have 11:23. Why don't you take till about 11:30? How's that? All right, hopefully that has helped a little bit. Give everybody just a minute. All right, how's everybody feeling so far? I know this is a lot of information and it's kind of a dry topic to talk about. It's hard to make diabetes fun. Everybody feeling pretty good so far?
For me, it's a lot of information really quickly. So I think this is one where I'm going to have to review a couple times.
Yes, I agree. It is. It's a lot of information. And there's some activities that I try to do, like when we're in class in a live setting, and I wasn't sure quite how to do those in this virtual setting. So what I did is I assigned you guys in Swift River one patient with diabetic ketoacidosis, because I think that's one of the biggest complications that you'll see trying to prevent. A patient that is post-op from a thyroidectomy, and one patient that is post gastric bypass. So I tried to do one patient of each of the kind of the bigger topics that I'm talking about. Now, I'm not requiring you to do those, but I think they will help you I think they will all help you in applying the information. So if you feel like you can go on there and do this patients with Swift River, then I feel like you're going to have a good handle of understanding the material. Does that make sense? Because then you'll be able to apply it if you know it. So I feel like they kind of go along with the topics that we're covering right now. Again, I didn't make a mandatory, but you have a lot of tools and resources at your fingertips too, to help. And so I thought that was one of those, when I looked through those, I felt like that was one that would really help. And I think I even included, I can't remember for this one. I think I included maybe one with medications.
Yes, there's a med pass to it.
This one or my perfusion class. I know I did some for the perfusion class. So there may be another one. Again, those are for your practice. And then when you're looking through your textbooks, the chapter, I don't have it written down in front of me, but your chapter on endocrine with diabetes, your chapter that covers thyroid, and then obesity. So like in your med-surg book, I would read through those just as extra. I know everybody learns differently. Some can get it after a lecture and take a notes, and some need to read the information, some need to see it. So I've tried to come at it from several different angles. And then I also included some Khan Academy videos, so that if you need to hear it in another way, then there's some videos in there too that are helpful. So I've tried to come at it from a couple different ways. So if you're one of those that likes to read the information and take notes, if you're one that can hear it and do well, or see it a couple different ways, and then the Swift River to help apply it all. So I've tried to give you some good resources to help just come at it from different angles, because I know a lot of us learn differently. Any other questions so far?
Yeah, I have a question. It's not in this, in this class because the Swift River that you assigned over there, some insulins, we had to have a second witness to administer it. Is that true? Do we need a second witness to administer some insulins?
Yes. Yes.
Okay.
Any other questions so far? All right, well, I will keep going, and we we should be at the point of kind of some complications with diabetes. So this slide, I kind of titled it sick day management. This is more for, so you have a patient that's just not feeling well. Maybe they've had some nausea, some vomiting. And so, some patients at this point just don't want to check their blood sugar and then don't take their insulin. So it's really important for them to continue checking their blood sugars, taking their insulin, and eating. So they can't, like if they're the nausea, they may want to reach out to the doctor and say, okay, how do I need to do this? Because they still need to check their blood sugars and then figure out that right balance of insulin and sugar. So they need something coming in. Maybe it's just fluids or something, but they need to figure out that right balance. So, so the point of this being, just because they're sick, they can't take a day off from it. The diabetes doesn't go away. So they have to do something to monitor that and make sure that their blood sugars are not going up. All right, so some acute complications of diabetes. So your diabetic ketoacidosis, it's a lack of insulin, and then you'll have the ketones. Your hyperglycemic hyperosmolar state, or also called HHS. This is very similar to diabetic ketoacidosis. There's a lack of insulin, and these patients are going to be pretty dehydrated. So the thing with, I know you guys just finished like fluid and electrolyte, and there's so many hyper and hypo to remember and to know. So the big thing with diabetes, whether it's type 1 or type 2, symptoms, there's a lack of insulin. So odds are they're going to have hyperglycemia. So then when you get to complications, no matter which complication, when I'm talking about these first two, the diabetic ketoacidosis and the hyperglycemic hyperosmolar state, both of these are still a lack of insulin and high blood sugars. So then your other complication for diabetes is hypoglycemia. So your hypoglycemia is going to come from either too much insulin or too little glucose. So your hypoglycemia is going to be your person who's exercised a lot, or your person who has taken too much insulin and then not had any food intake. So all of these can go bad really quickly. Again, the first two, they're going to have a lack of insulin, high blood sugar, and then your hypoglycemia, low blood sugar. So hyperglycemia. So again, those potentials with diabetic ketoacidosis and the HHS. And then you'll hear the Dawn phenomenon and the Somogyi phenomenon. And so those are the responses that can occur as well. For our purposes, I'm going to speak about the diabetic ketoacidosis and the HHS. So those are the areas that I want you to focus on for that. So your diabetic ketoacidosis would be, it's kind of, at this point it becomes, so again, these are complications. So at this point, it's an uncontrolled hyperglycemia. There's a lack of insulin, and the other regulatory mechanisms are kind of failing at this point. It most often occurs, diabetic ketoacidosis most often occurs in your type 1 diabetic, and is usually brought on because they're sick, there's some kind of stress going on in their life, they didn't take their insulin. Can y'all still hear me okay?
Yeah.
Okay, it's saying I'm having some internet issues, but so if at any point you can't hear me, let me know. So again, usually brought on by infection, some kind of stressor, sickness, or they haven't taken their insulin for whatever reason. Maybe they were sick, and then thought they didn't need to take their insulin, so then therefore that blood sugar starts going up. So your DKA, diabetic ketoacidosis, involves 4 problems. So you have your hyperosmolarity, you have metabolic acidosis, and I know you guys talked a little about that previously. We're going to get into this a little bit more. You have extracellular volume depletion, and then some additional electrolyte imbalances. So this becomes very serious, very fast, can lead to coma and death. So this can get out of control pretty quickly and become very serious. So they end up with severe dehydration and acidosis. And then certainly requiring immediate medical attention. They're going to get, with the dehydration, they're going to get a lot of fluids in that first 24 hours to replace any fluid loss. Because you're replacing this fluid pretty quick and it's going to be a lot of fluid, you're going to monitor for cardiac and respiratory complications. These patients are probably most likely end up in the ICU. That fluid replacement usually is going to start off with normal saline. They're going to need some insulin to bring the blood sugar down. And then a lot of these will end up on an insulin drip. And then oftentimes this causes, in these patients, the potassium level is decreased. So then you're going to replace the potassium. And then the bicarb will only, most centers are only replacing bicarb if the pH is below 7. Let me pause for just a minute. I see a few questions. Let's see. Okay. It sounds like somebody's having a challenge getting back on. Can you guys still hear me okay?
Yes.
Okay. Okay, so just to recap briefly, with your diabetic ketoacidosis. Okay, so again, think of your type 1 diabetic, think of your, you think of your college age student, I think maybe they're in nursing school, and maybe for stress relief, they are a big runner, and so they are out running a lot, and they're not managing their diabetes well because they're also stressed and they're running, not taking their insulin very good, and or maybe they get sick. Maybe they're sick and then not taking their insulin and are stressed because they're in college or whatever. So these patients then end up with that really high blood sugar. What direction is the pH going to go, high or low? If they're acidotic, which way is the pH going to go?
Low.
Low. So then they're going to be dehydrated. And then most commonly, it's going to cause potassium to go low. So hypokalemia. So then some of the treatment for that is going to be fluids. These patients are severely dehydrated, so you want to get those fluids in pretty quickly, but not to fluid overload them. So the first 24 hours is when they want to is the goal to get that fluid replaced. Monitoring for pulmonary edema and congestive heart failure, because you don't want to do it too fast, but it is pretty quick. Oftentimes these patients have a very high blood sugar. I'm talking like 400, 500, 600 high blood sugars. They could be unresponsive because of their blood sugar being high. It could even be higher, but 700, 800, or unreadable. So they're going to get insulin boluses or an insulin bolus, and then usually an insulin drip IV. What kind of insulin is going to be given via drip IV? Regular. So then you're going to check their electrolytes. Most of the time the potassium is low, so they're going to need some potassium replacement. Most of the time the bicarb is also low, but a lot of centers are not replacing that now unless their pH is at that 7 mark or 6.9 mark. So these patients also have, we talked earlier about the Kussmaul breathing. So they're going to have those deep respirations. They're trying to blow off that acid. So they're going to have that nasty, fruity breath because they're trying to blow it off. That's the body trying to help compensate for it. And so then what they need is that fluid replacement, so hydration, insulin, and then electrolyte replacements. And this is just this, again, I like these slides because they do a quick little summary for you. So the other complication, very similar to DKA, the other complication is your hyperosmolar hyperglycemic state. So this is usually your type 2 diabetics because they have a little bit of insulin on board. So remember, your type 1 doesn't. Your type 2 usually does. Usually their body's making some, it's just not working right, or it's not making enough. So these patients are going to look very similar to your DKA, but oftentimes they do not have the fruity breath. Sometimes they will, but a lot of times they don't. Because they're going to have enough there to keep that, they're going to have enough insulin to keep from becoming too acidotic. So usually these patients don't become quite as acidotic as your type 1 patients. They're going to have the high blood sugars. This is also life-threatening. They're dehydrated, so you're going to want to get that fluid replacement. Most likely going to be in the ICU. You're going to correct any electrolyte imbalances, give insulin and fluids. So your treatment for both of these is for your DKA and your HHS. Your symptoms and your treatment are almost the same. high blood sugar, dehydration. Your diabetic ketoacidosis, they're going to be acidotic because there's no insulin whatsoever. Your type 2s have a little bit of insulin, so it helps buffer that and they don't become quite as acidotic. And then your treatment is the same for both. You're going to give fluids. You're going to correct that dehydration. You're going to give usually a bolus of insulin. And then then usually an infusion of insulin to get those blood sugars down. Both patients make sure that they're ventilating. Some will end up on a ventilator, some not. A lot of them at this point are unresponsive, so some are going to need some help with that ventilation too. Okay, let me pause there. What questions so far with DKA and HHS? Mm-hmm. Yes, good question. And so let me explain that. Let me get back to my, okay, so typically your patients are gonna, if your patients are dehydrated, typically the potassium is going to be low, and so you're going to have to replace that. If you have a patient who is hydrated, that potassium level could be high. So the key to know is what are their electrolytes. You're gonna look at those, and then depending on what the potassium is, treat from there. Are they acidotic or not? And then most of the time they are on the dehydrated side. And when they are, that potassium is going to be low. There are times where they can have the high blood sugar and start in this hyperosmolar state, but they are hydrated. And so that's where I know it can be confusing, but your potassium then could be normal or it could be high. So it's going to depend on what all's going on in that sodium potassium pump and the balance of all of that and which fluids are pulling which electrolytes where. So with that, let's see, let me go back to here for you. So with that, in your treatment, first priority is getting the blood sugar down. Fluid replacement if they're dehydrated. And then correcting any electrolyte imbalances. Majority of the time, potassium is going to be low, but it could be high. But majority of the time, potassium is going to be low. Does that help?
Miss King, can you mute everyone's phone?
Can you mute everyone?
Yeah.
If you're not, just a reminder, if you're not asking questions, go ahead and mute yourself. I don't want to mute everybody because then you can't ask questions.
We cannot.
Right, Joel,
mute
can you
ourselves
mute your
if you
phone,
mute us.
Joel? I think Joel's on mute.
All right, I think that's better. Okay, did that help answer that question of why that has that? Okay. And that's a good question. Sorry, that's my dogs.
So basically, if you're hydrated, your potassium, if the patient's hydrated, the potassium is going to go up, but if you're dehydrated, it's going to be low.
Right. And so that's why you're going to want to check. Hold on a second. Let me close this door real quick. Hold on. Okay, sorry. So yes, so depending on the hydration levels, it's going to, because you're so, remember back to fluid and electrolytes, your sodium and other electrolytes are also going to impact your potassium. So depending on that status and where everything is will depend on where the potassium level is going to come back. Majority of the time with your DKA and HHS, majority of the time though, they're dehydrated, they need fluids, and majority of the time the potassium is going to be low and they'll need potassium replacement. That's not always the case, so that's why you're always going to check your potassium level and your bicarb level. You're going to do a blood gas because you want to know what their pH is. So you're going to check all of those levels and then treat accordingly. They're all going to get insulin and probably be on an insulin drip. Does that help? Are you guys still there?
Yeah, we're.
Okay. Just making sure I didn't lose everybody. Okay, any questions so far for DKA or HHS? Okay, so the next we'll do hypoglycemia. So hypoglycemia is a little more common with your type 1 diabetics. It certainly can happen from your type 2. It's just more common with your type 1. And then usually caused by one of these. So they've either taken too much insulin, they're not eating enough foods, or they're exercising a lot and not having enough intake to go along with that increased exercise. The thing with your type 1 diabetics is they don't have they don't have any reserve, to where your type 2 diabetics have a little bit of reserve usually. And then some just aren't aware to what those symptoms are in order to help monitor for it. So this is a great picture for hypoglycemia. So there's kind of these two little pictures here. So tired, if you think tachypnea, irritability, restlessness, excessive hunger, and then diaphoretic or depression. Think of those for your symptoms for hypoglycemia. And then on the right-hand side, this one kind of depicts, it's usually a rapid onset. They could be sweaty. So this is just another, this little guy on the bottom here is just kind of, all of these are very similar to your tachycardia, restlessness, hunger, diaphoretic. So that cool, clammy skin. So they need something to get that blood sugar up. Peanut butter, crackers, simple sugars to start with, but then something that'll last a little long term. Milk is another good one. To me, milk just sounds gross at a time like that, but it's another effective one. Some will do like orange juice to get it up kind of quick as well. So acute complications. If that blood sugar is going below 50 and stay in there, usually these patients will end up in the hospital as well. Those low blood sugars, these patients are at risk for seizures and then kind of becoming unconscious from there, having altered behaviors. They can become confused when that blood sugar starts getting low. So then the treatment, you're also, obviously you want to get some sugar in them. And then if you have a patient low blood sugars, the first thing you want to do is, if they're still able, if they're responsive and they can swallow, you want to try to get those sugars in orally. If they get to that point where they're not responsive and they're not able to swallow, then that's when you would revert to dextrose and glucagon. So once they're, so again, if they're responsive, they can take in those simple sugars, and then, you know, once that sugar comes up a little bit, then they could take in something else that would last a little bit longer. Peanut butter lasts a little bit longer. So you could start with like an orange juice or milk, and then something with some peanut butter or something to try to then keep it up. And then some frequent monitoring of their blood sugars. If they get to that point where they're unconscious, they're not able to swallow, then that's when you would use either the dextrose, and it would be a 50% dextrose, or the glucagon. And then again, frequent monitoring of their blood sugars. So I think I have, there's another picture that I had. So the glucagon, so the little saying they had for this, glucagon when the sugar's gone, as a way to know when to give it. So they don't have any sugar, so they need sugar. So it kind of shows the guy laying down at first. So you're giving it to them, and then hopefully then they become responsive, and then they can take in orally from there. So the biggest key is to try to prevent hypoglycemia. You know, educating them not to change insulin brands unless the physician's aware. Make sure they're taking their correct dose. You always want, especially for your new patients, or if a dose is changed, if they can demonstrate how to pull up the dose correctly and how to give it to themselves the dose correctly. That is super important. Make sure they're eating enough foods. You know, you may have some that want to go on a diet. And so how can they, you know, try to lose weight and exercise, but still make sure they're taking in enough food. Alcohol consumption is a big area. You know, there's still a lot of patients that want to drink. And so how can they do that and do it in a safe manner and not overdo it? Monitoring their blood glucose levels at night, and then making sure sometimes first thing in the morning when they're waking up, are they bottoming out during the night? And then wearing a medic alert bracelet so that others around know what to do if something were to happen. They become confused and they can't respond. So this is another good mnemonic. So that hot and dry, the sugar's high. And cold and clammy, they need candy, they need sugar, they need something to get at them. All right, let me pause there for just a minute. Any questions so far? All right, good to keep going? Y'all are a quiet group today.
So much.
It is. It's a lot to cut. It's a lot of information. Okay, so some chronic. So think of your DKA, your HHS, and hypoglycemia as acute complications for diabetes. And then you have chronic complications. So your chronic complications, there are, you have macrovascular and you have microvascular. So first we're going to talk about macrovascular. So your macrovascular are your large blood vessels. So think of coronary heart disease, myocardial infarctions, your left ventricular dysfunction, so cardiac dysfunction kind of covers that broadly. And then your cerebrovascular disease. Patients with diabetes, their risk for stroke is 2 to 4 times higher. Then they also have peripheral vascular disease. The key with this is controlling the hyperglycemia. The better you can control it, the fewer chronic complications. So then your microvascular, your small blood vessels. So think of your kidney and nerves and your eyes. So chronic kidney disease or end-stage renal disease. You're checking for both albumin and ketones in the urine. Albumin in the urine is a sign that the kidneys are not functioning as well, that they're not pulling out all of the toxins as well. Your neuropathy or nerve pain. So they may complain about tingling in their fingers or in their toes or legs. And then your retinopathy. And so when I was first kind of reviewing this, I found this number a lot higher than what I expected it to be. So I found that legal blindness is 25 times more common in your patients with diabetes versus without. So to me, that's a very high number, especially when it comes to your eyes. And then there's different types of retinopathy. And so the key to all of these is controlling the hyperglycemia. So the longer the hyperglycemia is out of control and the longer it stays higher, the potential for these chronic complications comes along. So if you go back to that slide, we had the A1C and the correlating blood sugar. If that A1C is consistently staying high, that 10, 12 range and consistently staying up there, then it means the blood sugars are staying high. So then patients that are high are going to be higher risk for these chronic complications. Your patients that are keeping that under the 6, 7 mark with their A1C are going to be lower risk for these chronic complications. So then what do you do with these macro and microvascular complications? So your neuropathic pain, I'm sure that you've probably, if you haven't, you'll see a patient on the gabapentin or Neurontin or the pregabalin Lyrica. These are great for neuropathic pain and helping with the nerve endings. Even though they're anticonvulsants, they work great for nerve pain. So you'll see that's how you'll see nerve pain treated. You want to monitor these patients for abnormalities with their feet. I don't know. I remember when going to taking my kids or myself to the doctor, they always had a sign up in the primary care office, that if you're diabetic, take your shoes and socks off. And so with those patients, you're checking their feet, make sure they don't have any sores, making sure they can still have their feeling. Do they have good feeling in them? Do they have good sensation in them or not? Other complications for diabetes can include sexual dysfunction and cognitive dysfunction as well. So surgery, they can do pancreas transplants and islet cell transplants. I think there's still a lot out and coming in these areas. I haven't seen this as much, but in the areas that I worked in, I wouldn't have. But these treatments are out there. I have seen them harvest islet cells for future transplant. And so I know they're working on a lot of different things to help patients with diabetes. Anytime, so this slide, anytime a patient with diabetes has surgery, this is a stress on the body. It elevates the blood glucose levels and then puts them at risk for diabetic ketoacidosis, strokes, kidney injuries. After surgery, they can have delayed wound healing, risk for those fluid and electrolyte imbalances, and then also risk for hypoglycemia, given that they're taking insulin as well. Sorry, dogs. I'm trying to wait till the dogs stop barking. So if they did, right, so if they do a transplant, usually it's a total transplant. Sorry, guys. Every time I think they're done barking, they're going to keep going. So with this, as with any patient that receives a transplant, they're going to end up on the rejection management. So the steroids, anti-rejection medications, potential for complications with this, blood clots, pancreatitis. They could have some leaking into the abdominal cavity, decreased renal function. So certainly focusing on the preoperative care, care during surgery, and then the care after surgery. I would say on a day-to-day basis with their primary care physicians, they're looking at foot care for your diabetics. A lot of them are going to end up going to like a podiatrist to have their toenails taken care of so that they're not, they don't end up with some bad ingrown toenail, or they don't cut themselves and then end up with a bad diabetic ulcer or diabetic infection there. So they're always checking for foot problems, abnormal skin conditions, checking their circulation, any deformities, do they still have their strength and their sensation? And so teaching, that care, making sure that they're taking good care of them, washing them, keeping them dry, avoid tight-fitting clothing. So you want them to wear shoes and socks because or shoes, something to protect their feet, and you want them to fit properly. You don't want them going around barefoot because they may be losing their sensation and not feel certain things. I actually had a cousin who lived in South Florida who he was older, and whenever, or it was an uncle, traffic was really backed up, and a lot of the people he was driving, and a lot of people got out of their vehicle to see what was going on. Well, he was barefoot. He's a severely diabetic, and he did not take good care of himself. Well, it's South Florida. It's hot, and it's a freshly paved road, and it's a blacktop road. And so he gets out barefoot and starts walking around and doesn't have good sensation in his feet, and ends up with horrible infections in both of his feet, which took forever to get under control, but ended up eventually losing a couple of his toes because of it. So hence, don't go barefoot on a freshly paved road in South Florida where it's very hot and you're diabetic. So telling the physician if you have any injuries to your feet, if you see any sores, so that those can be taken care of. just a few pictures. If they have a hard time looking at the bottom of their feet, they could use little mirrors. They can ask somebody else to look at them. So some different pictures of like a bad ingrown toenail, then trying to keep their feet clean. This bottom right one, some sores that can end up happening. And then so just the importance of good foot care. And again, this is to help decrease complications and help prevent potential amputations too. So for their eyes, you're going to have them do at least an annual eye exam. And then, and they'll want that with their ophthalmologist. And then for kidneys, doing a regular, their primary care physician doing a regular check of their kidney function. So in that, they'll be looking at their creatinine, their albumin, their overall kidney function there. So added the nursing diagnosis again, just to kind of highlight. And sometimes you guys are probably like, why do we need to know these? So to me, these, what they play into, for example, the neuropathy, so risk for injury with neuropathy. And so how can you teach the patient what to do for foot care, for example, so that then later they can prevent a potential amputation of a toe or even more to where it ends up taking part of their foot, or even goes even further to where it's their whole foot or even higher up into the leg. And so some of those amputations start with something simple, and then they escalate from there. So that's why I just decided to highlight those once again so you can see those. All right, that was a lot of information there. What questions do you guys have so far?
Just a knowledge question. I have a question about the pancreatic transplant. When these patients are giving a transplant of the pancreas, they're going to be put on steroids, and steroids would decrease their blood sugar. So,
sorry, you were breaking up. Can you say that one more time?
Can you hear me pretty good now? Can you hear me good at all?
Yes, I can now.
So I guess it's just a knowledge question. I don't really know, but I'm just asking, curious about the steroids management for the anti-rejection drugs for a patient that is giving another pancreas.
I heard you start, but then I didn't hear anything after that. I'm sorry.
I can just email it to you. It's just a knowledge question. It won't be, I don't want to confuse anybody.
Can you type it to me in the chat?
Yeah, I'll type it to you.
Any other questions? I think was that Shaniqua? Sorry, guys, mine faded out and came back in. Sorry about that. I don't know what just happened. Any other questions? I lose. Shaniqua, are you still there? Just if you want, just type it to me and I'll get it answered for you.
Okay, I'm fine too. I will.
Okay. Because I could hear you start to talk and then I couldn't hear you after that. I'm sorry. I think some of it is my internet at the moment. All right. Any other questions? So that covers diabetes. I know. So that's the heaviest one that we cover. That one has a lot of information. So I wanted to do it. I wanted to cover that today so that you guys have, I didn't want to do it right after your last test because I just knew that would not be a good time. So I wanted to cover that one today so that you have the most time between now and the exam for this one, because I feel like that one is the heaviest one with the most information. And then, let's see, today's Wednesday. So Monday we'll cover thyroid. And then the thyroid will be kind of the second one. And then the following Wednesday, I'll do obesity. And then obesity being the lightest of the three. And so that way, fortunately, you're not being hit with three heavy topics with this one. It is a lot of information. The most of it is in the diabetes part. And then, like I said, then the thyroid and then obesity last. So I will send a test blueprint. You guys can pretty much expect a test blueprint from everybody. Let's see. Okay, so one of the questions was about rejection medications and steroids being given. And then those steroids causing issues with the blood sugars. And so that's a great observation. So yes, anytime you have patients on long-term steroids, no matter what the reason that they're on them, they're gonna have to do something to frequently check those blood sugars for patients. So for diabetes, what I want you to understand is how to apply the information. And so if, what to look for and how to apply, and then your medications. So your diabetic ketoacidosis, your HHS, are complications, and your hypoglycemia. All of those are complications of it. And so know what to look for, know how to manage them, know how to prevent complications. Let's see. Let me find something real quick. All right, so a couple, so just to kind of review kind of what we've talked about a little bit. And so, all right, so a couple questions. So with diabetes, what would you say the ultimate goal is if you have a patient with diabetes?
To manage it?
Management.
Yes, management. And what are you trying to prevent?
Hyperglycemia.
Yes, because what can the long-term hyperglycemia do?
DKA.
DKA, what else? That would be acute. So DKA acutely. What else? What, think more chronically?
Coma.
Blindness.
Blindness. Blindness, what else?
Renal problems.
Right, renal.
Failure.
Transplant. We get a new pancreas.
Cardiovascular disease.
Yes, cardiovascular. And so when you end up with cardiovascular, what can happen with the feet?
Amputations.
Amputation.
Yes, that's where you end up with the risk for amputations. What are the three? So if you have a diabetic patient, whether it's type 1 or type 2, what are the three methods that you're going to make sure that you cover to teach them on how to manage? What three areas are you going to focus on?
Diet.
Are you asking about the polyuria, polydipsia,
Are you asking about those?
So, okay, so those are 3 symptoms you're going to watch for. Yes. So you would educate them on how to watch for those. I guess, so you have a patient that is already diagnosed, or they're just diagnosed with diabetes, and you're taking care of them in the hospital. What are you going to include in your teaching for them?
Like diet,
exercise, and medication management.
Yes, diet, exercise, and medication. Those 3 areas. Let's see. What are your side effects for your oral antidiabetics?
Hyperglycemia.
Hypoglycemia. And then if you have a person drinking alcohol and taking insulin or oral antidiabetics, what's that alcohol going to do to their blood sugar?
Decrease. Spike. Raise it.
Spike.
Increase, because alcohol. Yep, alcohol. Yep, alcohol has sugar in it, so it's going to increase. So you end up with that teenager that, goes on a drinking binge. They're going to end up with that high blood sugar. Okay, so if you have a patient, so if you have a patient that has an A1C of 9.5 and a blood sugar of 215, does this patient have good control of their diabetes? Yes or no?
No.
No.
No, it could be better. What do you want that A1C to be?
At least
7 or less.
Yes. Sorry, I had to plug in my computer. Yes, so you want that A1C around that 7 or under-ish mark. Kidneys. How do you know if the kidneys are still healthy?
Creatinine and the albumin.
Creatinine, what else?
Albumin.
Their output.
Somebody said something, but I couldn't hear. What would be the first thing that would alert you in the urine?
Ketones.
Oh, protein, the ketone.
Ketones, and there's one other thing that could spill into it. Ketones and
Glucose.
albumin. So ketones and albumin could spill into it. And you said the 3 Ps. So those 3 Ps are your signs and symptoms of hyperglycemia. So that's the polyuria, polydipsia, polyphagia. You also have weight loss. What's the biggest medication that causes hyperglycemia?
Steroids.
Steroids. Let's see. Okay, if you have a patient whose blood sugar is 650 and they're acidotic, what are you going to think?
DKA.
And they're spilling ketones.
DKA.
In their urine. Could you hear me?
That would be a DKA.
Yes, DKA. So what are you going to do for DKA?
Hang fluids.
Fluids?
Insulin.
What else?
Insulin drip.
Insulin, probably a bolus and a drip.
Bolus.
And then what else? So we've got fluids, we've got insulin, probably a bolus and a drip. And then
Electrolyte replacement.
Yes, we're going to check electrolytes. And so the other thing I didn't mention, so at some point, this patient is going to, so you're doing an insulin drip because that blood sugar is so high. So at some point you'll turn, if the blood sugar starts to come down, you'll turn off that insulin drip and you're probably going to use like saline, something without sugar in your IV fluids initially. But then at some point in that treatment, when their blood sugar gets back to normal, you're going to have to give them a little bit of sugar in there later down the road, but that's not anywhere in the immediate future. Does that make sense to everybody?
No. Repeat that.
Okay, so your diabetic ketoacidosis and your HHS patients. So before they hit those states, in their normal state, they're taking in sugar and they're taking in insulin, right?
Right.
Okay, so then they become acidotic and go into that DKA state or that HHS state where they're dehydrated, they need fluids, and because their blood sugar is so high, 700-800, their blood sugar is really high. So in that initial treatment is going to be the insulin to get that blood sugar down. They're going to be on an insulin drip. So say 24, 48 hours later, you're into the treatment with them and their blood sugar is staying at 100. What do you need to do?
Is that the part where you were talking about replace it with normal saline?
Say that one more time.
Is that the part where you were talking about replacing it with normal saline for that time being and then later giving them some sugar? I got confused. Right. Okay.
Yes. So down the road, not immediately, but yes, down the road, as that blood sugar returns to normal, you'll stop the insulin drip. And then at some point they'll need some sugar back in there. That makes sense?
Yes.
Okay, what are the signs and symptoms of hypoglycemia?
Cold and clammy.
Cold and clammy? So sweaty. High heart rate or low heart rate?
High.
High heart rate. Very good. And then what are you going to do to treat hypoglycemia? If you have a patient whose blood sugar's 60, what are you going to do?
Give them orange sugar. If they can take
Give them some kind of sugar to get it up. If you have a patient who then their insulin or their blood sugar is under 20 and they become unresponsive, what are you going to give them?
Like glucagon,
or like your D50. So they're going to get some sugar. So then your insulins, so you want to look at all of your oral anti-diabetic and your insulins. For your insulins, I would look at that whole graph with onset, peak, and duration. We talked about mixing clear to cloudy first.
Excuse me, Ms. Lynn. Did you say we should look at the peak and the duration of the graph?
Say that one more time.
You said we should look at the peak and the duration?
I think I picked up, yes, I think if I heard you correctly, yes, you need to look at the peak, onset, and the duration, all of those. Did that answer what you were asking?
Yes, it did.
Sorry, I think I'm having problems with my internet. Imagine that. So I think your question was, okay, you said you just sent me a message. Yes. Okay, perfect. Sorry about that, guys. So let's see. What is the only kind of insulin that you would use IV? Regular. And then what would be used in a sub-Q infusion, like in a sub-Q pump?
Rapid acting.
Rapid. Let's see. So if you have someone who's a diabetic, what else are you going to teach them besides, or let me ask that a different way. What about their medications and blood sugar monitoring are you going to teach them?
For them to take it even though they're sick or not feeling well, continue the regimen.
Right, very good. What else?
How often they should.
Right, how often? How often they should take the medications and check their blood sugars.
Educate them on signs and symptoms of when they're not feeling well.
Say that one more time.
I said educate them on signs and symptoms when they're not feeling well.
Whoever that was, sorry, I couldn't hear. I don't know if it's my internet again. I'm not sure. But yes, so teaching them rotating, if they're on insulin, rotating their sites, how to store their insulin, when to give it, and then in general, monitoring blood sugars, how often to monitor that. All right, any other questions? All right, I don't think I see any questions right now. If you guys have any questions, if there's something that you want me to go into a little more detail with, just let me know. I'm happy to do that. And then let's see, Monday we'll cover thyroid and then Wednesday obesity. So please don't hesitate to reach out if you have any questions along the way. All right. All right. Well, thank you guys. Y'all have a good rest of the afternoon.
Thank you. You too.
Thank you.